What's up? If you can hear me.
Yes, I can.
Perfect, perfect, perfect. All right. This is one of the most exciting days in my career with the Public Health 360 program. My name is Rami Azuine. I am the lead faculty here at the Global Health and Education Projects. We are based in Washington, D.C., kilometers out of the nation's capital. I am so excited to welcome you this afternoon to the Spring 2025 graduation ceremony of our distinguished Public Health 360 fellows who have joined us from across the world. First, I would like to use this opportunity to thank all our guests, all our alumni, all former participants of the program, supporters of GHEP, who are joining us live here or who will be watching this recording later on. I am so glad to have you as friends, as colleagues, and as collaborators. So, the Public Health 360 program is an immersive, intensive 3 months program where individuals from different backgrounds, physicians, pharmacists, public health students, um, emergency medicine physicians from every walk of life come and work with us for 3 solid months, trying to really arm themselves, empower themselves with the skills in public health. We believe that the training is so intensive that very, very few people complete the training from beginning to the end. And that is why we think that it is worth really celebrating for all our participants who have stuck in here. Many of these participants have joined the program late in the night, 11 p.m. in the night, some early in the morning, some, neglecting families, neglecting jobs, doing every other thing to really come to this day. So we are grateful for all what they have done. For today's program, we're going to have capstone presentations. And what does this mean? This means that we have provided cases, problems, public health problems to these Public Health 360 fellows, and we have asked them to design programs to solve those programs. Those problems are, some of them are local here in the US where GHE is based, some of them are abroad. And I hope that you are going to join us as we celebrate and hear from each of these groups. We have 4 groups today. Each of the groups we have 20 minutes inclusive, 15 minutes of presentation and 5 minutes for question and answers. For everyone participating, please use the chat function to ask questions. Pose any question, logistics question, questions about implementation, any question about even the individuals who are participating in the program. And then once we finish from each group, we move on to the next group, move on to the next group. At the beginning, each of the groups will introduce themselves, and they will also, in addition, help us understand the global community that is gathered here in this program by letting us know where in this part of the world they are joining the program from. All right, so without much ado, I would like to invite group number 1 to present for us. But before they do that, I would like to thank all the GHEP fellow team. Bram Magnus Olivers, who is ensuring that everything works perfectly, and also our guest lecturer for LinkedIn profiling, Dr. Susan Ekejuba, who is our resident data scientist and program director for all the support. Also thanking Dr. Zubi Nsoffer, who is the navigator that has spoken to each of you and that has given you the opportunity to practice this program. And the last but not the least, Dr. Chidubeme Boluche, who is our program assistant. Each of these individuals have contributed in pouring into you all the knowledge that we have collectively for over 50 years in public health, in health sciences administration, in research, in computer science from across the world. So thank you so much. Brown, do you want to turn the next slides? Yes, this is an introduction of our fellows. They're going to introduce themselves. You're going to see from the US, from China, from Nigeria, from India, from United Kingdom, from Ghana, I said that already. From Zimbabwe, the great country of Zimbabwe is represented here. So this is fantastic. But you're going to hear a little bit more about them. Jameson, the Roches, Jovens Alabre, Ifeanyi Chukwuka, Dr. Risha Bhattacharya, Kenneth Leninger, Dr. Maria De Matos, Precious Osawe, Renik Visi, Kevita Chand, Enoch Musingwini, Kehinde Aromalaran, Blaise Kunlamore, Deidre Hooper, Amara Oji, Ryan Benson, Martha Kunlamore, Doha El Jarari, Deidre Grant, David Osei-Dor, Retain Ehos, Sierra Martin, and the last but definitely not the least, Jemima Victoria Manfo. All right, so this is our contact. Please feel free to reach out. You can reach out to any of us. The email address that you'll find easy is info@globalhealthprojects.org. All right. Next slide. All right, so what is our affirmation for today? Our affirmation for today is I am a winner. Please use your chat and type in your affirmation. I am a winner. Keep it coming. Thank you, Doha. Come to Kende. Thank you, Blaze. Thank you, Sierra. Thank you, Kavita. Thanks, Ryan. Thanks, Jovens. Thanks, Deidre. You guys are moving so fast. Thanks, Jemima. Thanks, Ronique. Thanks, Jessica. Thanks, Jameson. Thanks, Renee. Retain. Thanks, iPhone. I am a winner, right? Many were called, but few got to this point. Thanks, David. Each of you should be proud of what you have accomplished. You know how many of you started this program, and you know how many of you are graduating today. So you are a winner. I am a winner. Next slide. Bram, please keep an eye on the waiting room so that you can admit people to come in. Folks, I know that this time in history is a very difficult time for public health. With all that is happening in the United States, with all the changes, with all people losing their jobs in the field, with agencies that are being dismantled, I know I am not oblivious. I know that this is a difficult time for public health. If you asked me 2 years ago, is public health worth it? I would say yes. If you ask me today, is public health worth it? I would say yes. If you ask me tomorrow, next year, is public health worth it? I will be yes. I will be yes. These are momentary, but I am telling you, you are going to be transforming societies. You are going to be transforming communities. You are going to be transforming lives with the skills that you have. Remember, hard times do not last, but really tough people last. So I know that. So we will be here all through to support you as you navigate the field, as you navigate to enter into the field. Professional advice, mentorship is always going to be there. But most importantly, leverage the community that you have been part of for the last 3 months. The word now is network, network, network. And why is that important? Because there is a hidden job market. That job market that is never advertised, that job market that is always word of mouth. So I encourage you, as you are graduating today, let it not be bye. Let it just be see you again. All right, group one. I know you are itching to start. Let us get into the business. Group one. Are you with me?
Yes, we are. Please, can everyone see my screen? Okay, I'll start sharing
Yeah,
now.
please.
Incoming. Okay, good morning, good afternoon, good evening, everyone. My name is Jessica Chikuka. I am from Lagos State, Nigeria, and I am the program director for Group One. Our program is Hope, a mental health outreach program for empowering teens. And these are my team members if they can introduce themselves.
I am Dr. Risha Bhattacharya. I am the Director of Clinical Services for our project, MHOPE. I am joining from Manipal, India.
Hello, everyone. My name is Jovens Alabri. I'm a Public Health 360 Fellow. I'm the Director of Outreach and Communications for the MHOPE program. I'm joining you here from Xi'an, China.
Hello, my name is Jameson DeWosh. I am the Director of Technology and Platform Development. I am joining from Florida, United States.
So this is our contents of what we're going to be presenting to you. What we're going to be presenting to you, and I'll be handing over to Dr. Risha.
Next slide, please. Coming to the first slide, it's like understanding the urgent need for intervention. As we all know, mental health challenges among adolescents have become a global public health concern, with depression, anxiety, and stress ranking among the top contributors to adolescent morbidity and disability. A 2021 UNICEF report revealed that 1 in 6 Nigerian youth aged 15 to 24 suffer from depression or anxiety, highlighting the urgent need for targeted intervention. In Nigeria, the issue is compounded by social stigma, inadequate mental health literacy, and limited access to mental health services, particularly in schools. Adolescents spend a significant part of their formative years within educational institutes, yet school health programs rarely include any mental health education or psychosocial support. So with the MHOPE program, uh, we want to uh, form a school-based initiative aimed at empowering students with knowledge, skills, and support system necessary to navigate these challenges. Second slide, please. Coming to why we have chosen Ogun State. In Ogun State, Nigeria, there is a growing anecdotal and observational evidence of psychological distress among adolescents. Despite visible signs of emotional strain, the existing school health framework in the area does not include structured mental health education, counseling services, or awareness initiatives. The adolescents often lack the knowledge to identify their own emotional challenges, and also due to the fear of being judged, they lack the confidence to seek help from the other people. The absence of mental health promotion effort at this critical developmental stage increases the risk of academic underperformance, poor interpersonal relationships, and long-term psychological issues. This project aims to address the systematic gap through a tailored evidence-based intervention called the MHOPE program at the Babcock University High School. Next slide, please. Coming to the goals, the overarching goal of the MHOPE program is to promote mental health awareness, reduce stigma, and strengthen psychological resilience among adolescents through a structured school-based education and wellness initiative. Our individual goals are reduce the prevalence of depression, anxiety, and stress among adolescents at Babcock University High School, enhance the mental health awareness, reduce stigma, and improve access to support systems through educational interventions within the school, incorporate wellness program into the school curriculum featuring activities such as breathing exercise, meditation, and grounding techniques. Over the next 6 months, we aim to promote healthy coping mechanisms for teenagers dealing with depression, anxiety, and stress. The next slide, please. The previous, yeah. To translate these goals into measurable outcomes, the program outlines the following specific objectives. By the end of 6 months, the MHOPE program aims to achieve a 30% reduction in DES-21 score, a 30% increase in the CDRISC score, and empowering the participating students aged 13 to 19 at Babcock University High School as measured through pre and post intervention assessment, and next to demonstrate improved emotional well-being and coping skills. Now I'd like to hand over to Jessica.
So this is our activities timeline. So it's going to be a 6-month program. The first month will be for the preparation and the awareness campaigns. There will be stakeholder meetings with parents, teachers, and the school management. Ambassador program where we would train up to 15 students, at least 15 students, to be able to create awareness with their peers. There will be an awareness campaign on social media, flyers and brochures will be shared. The second to fourth month, there would be bi-weekly workshops where we would do incorporate workshops for the parents and the teachers where they would gain mental health first aid training and the students would learn healthy coping strategies like mindfulness and mindfulness, sorry. Then the weekly peer support where students would be able to speak to their friends, to their peers. We would create like a safe space for them. There will be counseling services for those who suffer from depression, anxiety, and stress. Monthly wellness days where there would be yoga, exercises to help distress, basically. Then the final month will be the final assessment. That's the evaluation and sustainability. There will be final assessments where the evaluation would be done. We would share the questionnaires for the DAS-21, that's the depression, anxiety, and stress questionnaires to help assess what they've learned and how how their awareness has increased. There will be a community showcase where we would share the testimonies of the participants. The sustainability plan, we plan on training at least 10 teachers to be able to also educate and create more awareness because awareness has to be created every single time for mental health. So there will be a sustainability plan. We will train at least 10 teachers to educate the students, to also be a safe space for the students to be able to come to them and talk to them about it. So during this, incentives will be shared as well. The first month, the student ambassadors will get a t-shirt and early registrants, like the first 100 maybe, would get wellness kits that includes stress balls, coloring books, and things that just basically helps them distress. The second month, 80% students with 80% attendance will get badges, while the parents and the teachers will receive a certificate of participation. Then the evaluation and sustainability for the last month, the incentive will be funding or assistance for the school health clubs that will be created for this cause. Moving on to the potential barriers. So during the course of the program, we expect to face stigma and reluctance to participate. Stigma and reluctance to participate. Maybe they feel that they'll be labeled as weak in front of their mates. So we would address this by using the peer ambassadors to normalize conversations. The second one is the limited parental and teacher involvement. We will offer flexible workshop hours and training certificates for teachers. For the parents and teachers, they may be busy during the day, so they can't really attend the workshops. So we would do like an online workshop for them to educate them also. Resource constraints, that's lack of resources, funding, and all. We'll partner with NGOs, prioritizing low cost activities like peer led clubs, which is actually a very good one. So we would create school health clubs for the students where it would be a student body that will head it with the assistance of the teacher. Then the sustainability challenges, that's the training group of teachers or students to lead activities, advocate for policy changes to embed mental health policies in school. The expected outcomes. So for this program, we expect that there would be a reduced stigma around mental health discussions, strengthened emotional resilience and coping skills, sustainability, community, and institutional engagement. I would be handing over to Jovin. Thank you.
So now you've been introduced to the need of mental health among teens in Ogun State, and also the different interventions that we'll conduct to first raise awareness, educate our participants, and also empower them. Now, the question is, how will we evaluate the success of this program? So this is where I come in to tell you about our evaluation plan. Now, moving on to the next slide. So the first thing that we'll be looking at, the next slide. So the first thing that we'll be looking at is a reduction in depression, anxiety, and stress, and specifically a 30% reduction. Now, to do so, we'll use the DASS21 scores. And the DASS21 scores is, so first of all, it stands for depression, anxiety, stress scales with 21 items. And it is a short questionnaire that measures how much someone is feeling, depressed, anxious, or stressed. It has 21 questions, and it is divided into 3 parts. And also people rate how much they've experienced certain symptoms over the past week. And we'll do 2 evaluations, pre and post intervention. And although this questionnaire is the standardized psychological scale, we'll make sure with our partners that this questionnaire is culturally adapted to Ogun State. So that is the first thing that will be evaluated. Now, moving on to the next slide. So the second thing that we'll be looking at is an increase in resilience among the students aged from 13 to 19 years old, and 30% increase in resilience. And we will use the CDRISC score. Now, it stands for Cognitive Resilience Scale. So it is a tool. It is a tool used to measure a person's resilience. Basically, how well someone can bounce back from stress or adversity. It has 25 questions, and people rate how much they agree with statements about handling tough situations. And also we'll make sure that this questionnaire as well is culturally adapted to Ogun State. And we'll also do a pre and post evaluation program evaluation. So these are 2 things. And the third thing that will be evaluated in the next slide. So we'll be looking at how well the participants, the teens are doing emotionally. And to do so, we'll conduct a focus group and behavioral observation And what we hope to achieve is to equip them, the students, with actual strategies, coping strategies for them to be doing well emotionally. So these are the three things that we'll be evaluating in our program. Now, moving to the next slide. Now, a program at this scale, our leadership team, the mHOPE program leadership team cannot carry it out on its own. So that's why it is important for us to partner with local organizations that are in the field working. And first, before I introduce you to our partners, let me give you a brief introduction to the mHOPE team. First, we have our program director, Jessica. So Jessica is located in Ogun State. So she's very well aware of the local community. So she'll be overseeing the program and also do coordination and also strategic direction and make sure that our intervention, they comply to local guidelines and rules. And second, we have our clinical director, Dr. Risha. So Dr. Risha will be closely working with one of our partner, designing the educational materials, the interventions, the counselings, and also the support groups to make sure that everything that we design is evidence-based. Now, third, we have myself. I, as the Director of Outreach and Communication, I'll be ensuring first internal communication and external communication with our partners. And I also make sure that our awareness programs, our engagement is based on taking into consideration the need of youth and also all our public education as well. And fourth, we have the Director of Technology and Platform, Jemson. So Jemson will be looking at the platforms that we'll be using to train, to receive feedback, and also to report the program. Moving on to the next slide. So in part of our leadership team, will be recruiting 2 consultants. First consultant will be a mental health content creator, will be working closely with Jemson. And what we'll be looking at is someone who has a background in either psychology, public health, or communication, and so with skills in content creation. And the second consultant that we'll be recruiting is a monitoring and evaluation consultant, someone with a background in public health, epidemiology, or related field, and someone who has at least 2 years experience in monitoring and evaluation, and with skills in qualitative and quantitative data analysis. So this is what the mHOPE team will be looking like. And moving next to our partners. So now, before I start talking about our partners, what we want with the mHOPE program, we want this program to be designed by the community for the community. So what does that mean? That means that we have to collaborate closely with our partners, and our partners are already in the field working in mental health in Ogun State. So first is the Babcock University High School. So this is the local school where we'll be conducting the workshop, the counseling, the support group, and also to engage with the teachers and also the parents. So this is our first partner and main partner, the Babcock University High School. Moving on to our next partner. Next partner is Babcock University Teaching Hospital. So this is where the clinician, the psychologist will be coming from, and to make sure that all our educational materials, the training modules, everything is evidence-based. And also, the partner will be working closely with Dr. Risha. Moving on to the next partner. Our next partner is a mental health community service, and they are already in the field working in mental health. So they'll be leading awareness campaigns, make sure that everything that we design is relevant to teens, and make sure it also culturally adapted to the also to the local need of teens in the local community. And moving on to our fourth and last partner. Our fourth and last partner is Mental Health and Wellness Initiative. Now, this local organization, they organize the workshop, webinars locally in Ogun State, and it is a non-profit and non-governmental organization that aimed at creating awareness of mental health in Nigeria. So what they'll be focusing on is they'll be co-leading advocacy and stigma reduction, and also to engage families and parents into the program. So this is how the partners that will be working on closely. Moving on to the next. Now, each of our partners, they complement each other. First, the school. This is where we'll conduct the workshops. The community health services, they will be focusing on research. The mental health wellness initiative, they'll be focusing on advocacy. And the hospital, they'll be focusing on designing the program. So that's what I mean by this program will be designed by the community for the community. Now, moving on, I would like to hand over to our next presenter, Jameson. Now, Jensen will be presenting the dissemination strategy.
Sorry, I was on mute. I didn't see that. So now we move on to this dissemination strategy that we will use for our program. Next slide, please. Okay, this is the strategy that we will use for the program. So technically, we will focus on three phases for this program. We will have like before and during and after program. So the goal for this program is to engage, provide transparency and sustainability. So also we will target audience include adolescents, schools, NGOs, policymaker, and the general public. So the tools that we will use like QR code, social media, email, stockholder briefing, and also has partner. We will use Money, which is one of the program based on Nigeria. She White Woman, Psych NG services. So those are services that we will partnership with. Next slide, please. So before the program, we will, technically we will engage in initiative like where we will talk to school principal, parents, and teacher and associations. Also, we will collaborate with local mental health NGOs. So like how we're going to distribute, we will do flyers, brochures, and poster, and also we will feature in QR code, link to introductory mental health video. We will create video and distribute it in school and community. Also, we will use email newsletter, like we will create a WhatsApp group campaigns, and we will launch gathering for those who doesn't have access to the internet. So also we will use bulletin board, like putting like big sign on the street, like where people passing by, they can see it and they can learn about the program. And also we will use public space where we will have the opportunity to meet a lot of people. Next slide, please. So during the program, technically during the program, we will have a weekly update where we will share our social media platform. Like, for example, using the hashtag of mhope14. Also workshop and key session. So technically we will have workshop and key session where we will have like a live stream where people who has internet can watch us online. So also we will use a testimonial from the people who participate in the program, and they can share like how effective the program is. So also policymaker and stakeholder will receive pediatric update, digital briefing and progress. Technically, we will send out like email and update to let the people know how the program is going. So my program insight will be used to foster ongoing community partnership and support. Technically, we will continue looking for partnership for our program. Next slide, please. So after the program, we will have like a final report. We will have like infographic and summary video. We will developing like highlight outcome. We will have highlight outcome and then to show what we did. So as a result, we will share via email, social media, and NGOs platform. So technically, we will use the influencers, all type of social media to share what we did about our program. So a community event will be held present, finding and celebrate success stories. So technically, we will have like a community event where we will like share about our story and how we make success with the program. Also, we will continue have people give us give testimonial via digital story. They will publish it and amplify program impact. They will talk and show how the program is impact in their life. So dissemination material will support advocacy for scale up by local government agency. So we will reach out to the local government agency for help, just to make sure our program is still continue after we establish the program. Next slide, please. Hello? Can you hear me? All right, so the next we will have our budget table, how we will use the fund that we receive for the program. Next.
Jovins, Jameson, you need to walk through. You have only 2 minutes left.
Okay, so technically this is our table for personal. This is how we will distribute the money: personal, contract, consulting, and supply material, technology, and indirect costs. This is how we will use the money every month. Next slide, please. So this is a budget distribution by percentage. For personal, we will use like 58.5% of the fund. Consultant 9%, supplies and material we will use 19.5%, technology 5.5%, indirect like for all the stuff we will use is 7.5%. Next. So this is our conclusion. Hope is a data-driven school-based intervention tackling adolescent mental health in Babcock University High School with measurable impact, strong community support, and scalable design. It's offer a sustainable path forward to teen well-being. Thank you.
Excellent, excellent. Thank you so much, Group 1, Hope, Mental Health Outreach Program for Youths in Nigeria. Please join me and let us give them a warm hands, of applause. All right, I have questions pouring in here. We got to do a better time with time. I have questions here. So the first question I have for the group is, why Ogun State in Nigeria? Why did you select Ogun State in Nigeria when GHUP is based in the United States? Who wants to go there?
I can answer that. So, GHUP is based in US, Maryland, US, but we decided to work with Nigeria because when we talk about mental health, coming from someone that's in Nigeria, mental health is not really discussed. It's not a topic of importance in Nigeria, especially among teenagers. So it's like we need to raise awareness for teenagers that are suffering from this. And Ogun State is okay. And Ogun State is where I school. I go to school in Ogun State, Babcock University. So there is a connection that will facilitate easier process for this program if it is to be implemented. So yes, there is a high risk of teenagers relying on substances to get through life, basically. And we, as a public health professional, we can't just stand by and watch these teenagers waste their life um, focusing on substances. So there needs to be an awareness, especially in Nigeria as a low income country, basically. The economy, the government, politics, everything affects the mental health of teenagers. I don't know if
Thank
that
you.
answers the question.
Yes, thank you. Thank you. So I have a second question here saying that I see that you are going to use a number of assessment instruments. How will you use those instruments in Ogun State? Are you going to translate or something like that?
I'll go ahead and answer. So those questionnaires, they are in English. So they are in English. And also what we'll make sure is make sure that they are standard questionnaire. So we cannot just take those questionnaire and use them in Ogun State. We have to make sure that it reflects the local need of teens. So that's why we'll be partnering with the organizations that are already working on site. If we need to do translation, we have to modify questions. And so all those modifications that needed to be done that can reflect the local need of Ogun State will be done with our partners.
Now, one final question, and then we'll move to group number 2, is a question about your budget. This is more of a comment. The person said that I looked at the budget pie chart and you are spending the most amount of money on personnel. This is incorrect. This is wrong. Yeah, I think that is valid, right? We say that when you are designing a program, the largest amount of resources for the program should go to the implementation of the program. You shouldn't be using the funding for the program to pay your staff, to pay your consultants. Majority, I think 70% of the cost of the program should go to direct services that are going to touch the clients rather than payment. I think in your slide, 70% is personnel. So this is a very good call out. Thank you so much. Any other questions? Anybody has questions who wants to unmute and ask question? All right, please use your reaction button and let us give group 1 a resounding applause. Use your react button. Select what you want to give. Thumbs up, rocket, love, balloon. You give them what you want to give to them. Thank you so much. Thank you. Really appreciate the team from with team members from the USA, from China, from Nigeria, from India, working together to solve a problem in Nigeria. This is great. Thank you so much. Okay, so we are moving to group number 2. Group number 2. Please, you can share.
All right, can everyone see my screen here?
Yes.
Perfect.
Yes.
Thank you. Hello, everyone. Welcome. Thank you so much for spending your Saturday with us and showing your support. We really appreciate it. Today, we're presenting to you our program, Movement for Health, aka M4H, a program to increase physical activity for African-American women. I am Kenneth Lininger, the project director, calling from San Jose, California, in the United States. Next, we'll have the rest of the team introduce themselves.
I am Blaise Kunlamo, Director of Monitoring and Evaluation. I'm currently joining from Abyei, region between South Sudan and Sudan.
Hello, my name is Cedar Hooper, and I am the Director of Technology and Platform Development.
I'm joining from Alexandria, Virginia in the United States.
Hello, greetings. My name is Enoch Msungwin. I'm the Director of Strategic Partnerships. I'm joining from Harare, Zimbabwe. Good to join you. Thank you.
I'm the Director of Outreach and Communications, and I'm joining from Modesto, California in the US.
Hello, I'm Kende Arumolaro. I am the Clinical Director for this project, and I'm joining from Abuja, Nigeria.
All right. Then we'll give it over to Kehinde.
All right, so we're starting off with a problem statement for this project. So African American women aged 45 to 64 in Quitman County, Mississippi are the target population for this project. And why have we considered this population? Research has shown that higher levels of inactivity are seen amongst the Blacks in the US compared to their white peers. And also, according to the US Census Bureau, about approximately 72% of the population in this community identify as Blacks, and over 25%, that's at least 1 in 4, are living below the poverty levels. So this is quite significant because physical inactivity has been linked to lower income levels. And also in this population, there is a high rate or disproportionately high level of obesity, chronic illnesses, and even death amongst this population, although these are usually preventable by encouraging physical activity amongst this population. So let's take a look at the statistics. Next slide, please. So why does it matter? Physical inactivity is a major predisposing factor for several chronic illnesses. According to the WHO, physical inactivity is the 4th leading cause of death worldwide. This is quite significant, and that is why we are considering this topic. 31% of the world's population also fail to meet physical activity guidelines. According to the WHO, the physical activity guidelines include at least 150 minutes per day of moderate intensity physical activity, or at least 75 minutes of vigorous intensity physical activity. So in the US, 36% of adults report absolutely no physical activity, according to the CDC. And amongst the African American women, which is our target population, according to the CDC, 55.9% are obese. And chronic illnesses like hypertension, diabetes, and heart diseases are 2 times more prevalent compared to other groups, according to the Office of Minority Health. Also, physical activity rates are 30% lower than any other group amongst the African American women. Next slide, please. So, considering the goals and objectives for this project, the Movement for Health program aims to increase physical activity to 150 minutes per week for 70% of Movement for Health participants in Quitman County within 6 months. We also aim to establish at least 3 community-led wellness groups by the end of the pilot. And by the 3rd month, we aim to reduce sedentary time by 30 minutes per day. So it's important to distinguish, like, this sedentary time is referring to the time that is spent engaging in no physical activities, such as leisurely watching the TV, scrolling on social media, just no body movement, while physical inactivity is failure to maximize or failure to accomplish the guidelines stipulated by the WHO. So by the 3rd month, we aim to reduce the sedentary time by 30 minutes per day. Over to you, Deidre.
Movement for Health will use a multi-pronged approach that integrates physical movement, health education, digital engagement, and peer support. A multi-pronged approach within Movement for Health campaign refers to the use of several coordinated strategies targeting different levels of influence, individual and community, to promote physical activity and reduce sedentary behavior. Participants are engaged through faith-based partnerships, culturally relevant fitness classes, and motivational workshops designed to build long-term wellness habits. Our goal is to create a scalable model that is not only improves physical activity levels in Quitman County, but can also be adapted for similar communities across the rural South. I'll be followed by Blaze.
a successful and effective program to reduce physical inactivity by fostering sustainable habits of regular exercise and encouraging healthier lifestyles. And all these are geared towards achieving the following benchmarks outcomes. At least 70% of movement for health participants enrolled to obtain progress towards or even meet the widely recommended CDC WHO threshold of 150 minutes of moderate intensity physical activity every week, which intensity will be relative to each participant. And the expectation is to achieve this within the 6 months of the program. We also, another outcome is to, it's well known that cardiovascular disease is a leading cause of death in the world. And so addressing this is especially important to the Movement for Health program. So by enhancing cardiovascular health through the increase in cardiovascular fitness for at least 50% of participants within the 6 months period. Then we are also looking at reducing time spent being sedentary, yes. So the Movement for Health program will focus on decreasing sedentary behavior by estimated daily average minimum of 30 minutes within the 3 months from the start of the program. And this is important because sedentary behavior is linked to numerous adverse health outcomes. And we are also going to we also aim at promote consistent program participation. And our key focus for this outcome is to accomplish no less than 70% of attendance of scheduled sessions by at least 80% of Movement for Health participants during the first 6 months of the program. And then finally, to foster a long-term behavioral change that would contribute to overall wellness beyond the period of piloting the Movement for Health project. So the program seeks to produce measurable, sustainable, and realistic incremental positive health outcomes. At this point, I'll hand over to Deirdre to continue with the target population.
Our primary target population is African American women ages 45 to 65 living in Quitman County, Mississippi. For those unfamiliar with the U.S. geography, Quitman County is located in the southern region of the United States within the state of Mississippi. It is part of the Mississippi Delta, a historically Black rural region known for its cultural richness and, unfortunately, its persistent health inequities. This community faces elevated risks of obesity, heart disease, hypertension, and diabetes, many of which are preventable. Women in this population often serve as caregivers, decision makers, and health influencers in their families. By focusing on them, we aim to improve individual health while also creating ripple effects across households and communities. Next slide, please. Quitman County has a population of just under 7,000 residents, and more than 72% of them identify as African American. The county experiences some of the highest rates of poverty in Mississippi, with over 1 in 4 residents living below the federal poverty line. Life expectancy here is significantly lower than national averages, and access to healthcare is limited, with very few local providers and no major hospital in the county. Public health data highlight multiple urgent needs, increased physical activity, chronic disease prevention, and better access to culturally relevant wellness resources. Our program is designed to directly address these needs while removing some of the structural and cultural barriers that have historically prevented engagement in formal health programs. Next slide, please. We chose to focus on African American women in Quitman County for 3 main reasons. First, they are disproportionately affected by preventable chronic diseases that are closely linked to low physical activity levels. Second, they often face multiple intersecting barriers, including transportation, caregiving demands, safety concerns, and cultural perceptions about exercise that make it harder to engage in regular movement. And third, and most importantly, these women are powerful health influencers within their family and communities. By empowering them, we not only improve health and individual outcomes, but also support community-wide cultural change. Their participation helps normalize physical activity as a communal, joyful, and accessible part of daily life. I'll be followed by Kenneth.
And here we can see a basic implementation timeline for our program, and it's 6 months long, designed to be a pilot program to assess the applicability of our program to potentially other places. Starting here with the most underserved of the most underserved, we figure if it works here, it can work most anywhere. And like I said, each month is divided up into different sections. Although some of this can be flexible, such as the first 2 months here. Month 1 is for outreach and recruitment, partnering with local organizations and entities, recruiting members of the actual community to help spread the word about our program and to provide a cultural ambassador for our program to the community. And then also month 2 onboarding, getting people enrolled in our program and obtaining baseline measurements. So these things could happen concurrently as we onboard people or as we recruit people, or could separate it into the different months. It's flexible. And next we have the next 2 months of the program. Month 3 is where we begin to go full force with our programming and our interventions, our health education workshops, really integrating into the community, local churches, community centers, that sort of thing, and get things rolling with the program. And month 4 will be monitoring of interventions, of participant attendantship, things like that, making sure that people are feeling comfortable in the program, they're progressing, or at least, following what is asked of them and still willing to proceed in the program. In the final 2 months of the program itself will be continued support and feedback, will be ongoing evaluation during the program itself, and getting actual feedback from the participants so we can help fine-tune our processes. And then month 6 will be where we will start to really dig into the data and see what changes may have happened over the course of the program, and see what we can do for the future to make our program sustainable, see how we can get start to lay the groundwork of how we can get excess funding to see if we want to continue or move our program somewhere else. And of course, we added a month 7 and beyond, continuing the data analysis, seeing now that the program is finished, we have all the data, we have everything we need to assess how the program went, and we can start to really focus on getting other sources of funding, such as through grants to organizations, fundraising through the community, donors from elsewhere. This is a very important issue that we hope to get the idea across, that this is the most vulnerable of the most vulnerable of the most vulnerable. Yeah. And next, I will bring it over to Enoch.
Thank you, Program Director. As you know, public health and NCDs being a topical issue has already been alluded to. We can't just leave it to health professionals only. So strategically relevant partnerships are very important. One of the aims of our partnerships will be to foster shared goals with different partners, including the churches, Medicaid organizations, universities. The communities are going to be embedded within the project as a very key aspect of sustainability. By working together and co-creating this in a partnership mode with African American women is going to promote sustainability, and they're also going to be meaningfully involved. We're also going to seek support from the community. We're also going to have a lot of outreach, working together with the churches and other community-based organizations so that we are able to reach, and they're also able to guide us as the senior leadership team in terms of the local nuances, that we're able to understand the local dynamics. It is also good in terms of program sustainability. Partnerships are also going to be important in terms of amplifying impact through collaborative advocacy. We are going to engage the local political leaders. As you know, from the social determinants of health model, some of the aspects that affect African American women, they might need to be addressed from the political perspective, where political leaders and policymakers need to take a deliberate approach to support and promote equality within the community. Next. just a list of various partnerships which we envisage to engage. We might even discover more, but for now, this is what we've listed: the National Women's Resource Center, Delta Alliance Congregational for Health, which is part of one of the churches, Pinecrest Baptist Church. The church is a very important community. As you know, religious leaders, they also yield a lot of power. They can also influence a lot of normative behavior change. Their messages are also going to be resonated and respected. So we're going to really collaborate well with the churches and a lot of other like-minded organizations. I've already alluded to the private sector, the Medicaid and other coordinated care organizations, our local universities, even in terms of designing appropriate awareness materials, and you can even also engage in operational research to evaluate our work. I've already talked about policymakers. Next. This is just a description of the organizational structure of the project team, the senior leadership team. A very able team, as you've seen from the first slide, in terms of the qualifications, experts and diverse backgrounds, led by our able program director and the various supporting team. Next. Just to highlight the few areas that our key leadership team will be taking, our program director takes the overall lead in terms of coordination, overseeing the direction of the project. Our clinical director will be specific in terms of clinical and health-related things, so that everything that we're going to be doing is in line with correct facts and information as far as the clinical aspect of things are concerned. Our director of M&E will be there to set the baseline, design our tools, so that we are also able to track if we're in the right direction. Do we need to replan? Are we in the right direction? Are we meeting our targets? Then we also look at the director of strategic partnership. Myself, I already alluded to the role. Key to it is going to be issue of sustainability, as well as additional resource mobilization, so that even if we're going to leave after this 6 months pilot, the gains can still be sustained. The communities can still continue to engage in physical activity with support from the church, encouragement from the peers, and also other local-based organizations can also take the baton to continue to yield the dividends that would have been achieved by the pilot project. Director of Outreach and Communications is going to be key as far as working with the community, embedding our program so that it is accepted, it is also culturally relevant, it has got the blessings and support of the local community. Director of Technology and Platforms Development, as you know, digital health is coming. Digital health is with us, and we can only leverage on this so that we are also able to amplify our work and utilize the various aspects of the digital health, the text, the different apps. Next. In addition to the senior leadership team who give the strategic direction and guidance, we're also going to have operational team working hand in hand with the local community. We have a program manager. We also have a variety of community healthcare workers who work with the director for outreach to make sure that we get into the community. The message is going by word of mouth. We're also going to distribute a lot of materials to make sure that the local African-American women will get all the messages. We also work with peer ambassadors, as also the local people recruited from the local community, so that there is acceptance. They're also able to guide us in terms of local nuances. We also have dedicated volunteers, people who are willing also to dedicate their time to provide and support for the project. Key to it, we're also going to have evaluation staff working together with the director for monitoring and evaluation. We are going to do surveys, track our data, make sure that we're able to document the progress that we have done. Next. I hand over this to Blaise.
Okay, thank you, Enoch. So this comprehensive approach will enable the full picture of the movement for health participation outcomes. So in the program, we are aiming at evaluating these outcomes through a number of activities. The first will be as surveys and questionnaires, which will be administered to the participants. And behavioral changes will be monitored for progress over time. For movement of health participants, they will be required to complete a structured survey at the beginning of the program, midway, and at completion. And these instruments will be captured self-reported data on physical activity levels, on sedentary levels, and then also the overall status. And we'll be utilizing tools and techniques such as internationally recognized International Physical Action Activity Questionnaire, the IPAQ, to assess the movement for health participation activity for these participants. And this tool would ensure reliability and comparability across the time points. Furthermore, activity monitoring will be done in order to track the program using digital tools and devices, which will ensure that we provide objective and real-time data on the steps taken, minutes of activities, and intensity levels, allowing accurate tracking of movement for health individual progress. Now, the tool used would include wearable activity monitors or devices like the accelerometer, pedometer, and the mobile fitness apps. And again, these devices will ensure that we obtain consistent and objective data throughout the program. We would also, as part of the evaluation, look at the fitness assessment, which will be conducted in order to evaluate changes that would have taken place during the physical activities. And each movement for health participants will undergo uniform, standardized fitness testing. And these assessments would occur also at the start and the conclusion of the program in order to identify improvements in cardiovascular capacity and the physical endurance of each participant. And again, would employ the use of the maximal aerobic capacity, also referred to as a maximal oxygen consumption or maximal oxygen uptake. And this would ensure that the physical fitness improvement over the period will be assessed in order to ensure that there's cardiovascular performance and muscular strength as well. Next, please.
Please wrap up in
Dr. Remy?
2 minutes.
Yes, Dr. Remy. So for data collection, we're going to do it across the following categories: the physical activity, the sedentary behavior, and then the fitness level. Next slide, please. Also, and the outcome-based evaluation tool will be gauging the improvements in physical activity, reduction in sedentary time, and then the fitness enhancement as well. Please, next slide. So, okay, in evaluating, sorry, the previous slide. So in evaluating the program's implementation and reach, we are going to, we are going to look at the attendance and engagement, where participant attendance will be recorded and then to monitor for consistency and commitment over the period. The program reach will also inquire the individuals enrolled and served throughout the program will be recorded in order to determine the overall reach and then community penetration. And then finally, the retention rate, where we are hoping to push for the program to be evaluated for its ability to maintain interest and encourage long-term participation, so that even beyond the program, participants will continue. And then we'll finally look at assessment and capacity building sustainability, where we'll look at staff training to evaluate their preparedness to support the program to ensure its success, and then community partnership also training to ensure that the movement is integrated in community and successful. And then the long-term sustainability, also, like I said previously, we are looking at it going beyond. So we'll analyze the potential of it, ongoing operation, means the scalability of it, and the long-term impact. Thank you. I'll hand to Ken for nomination. No, Kavita, sorry.
Hello, I will be going over everything extremely briefly because we don't have enough time, but I'll be walking through our dissemination strategy, which is focused on making sure movement for health is visible, trusted, and deeply rooted in the community. We've structured our approach in 3 phases. So before the program, we'll build awareness by sharing plain language, flyers, in churches, salons, and other local spaces. Peer ambassadors will support word of mouth outreach and will run early promotions on radio and social media. During the program, we'll keep participants engaged through weekly social media posts, newsletters, text reminders, and a podcast series on topics like self-care. We'll also highlight participant progress through short stories, short videos and storytelling. I will lead the strategy with Deidre managing digital tools and then local ambassadors supporting in-person outreach. After the program, we'll share results through a policy brief, a community celebration, and presentations to HBCUs and public health groups. All materials will be accessible in large print, audio, and plain formats. This strategy is fully supported by our budget and ensures the program is visible, inclusive, and built to last overall. Next slide, please. Okay, I am also going over our budget. So these are core investments. Our $200,000 budget overall centers on community impact, cultural relevance, and sustainability. The largest share does go to personnel, covering outreach, evaluation, coordination, and tech roles to ensure the program is managed effectively and culturally aligned. We've also invested in community-based events like walking groups and wellness sessions to foster connection and support behavior change. Subgrants will go to churches, HBCUs, and nonprofits to ensure the program is led by trusted local partners. Next slide, please. For engagement and access, this part of the budget focuses on how we reach participants and track impact. We've allocated funds for marketing and media, including social media, radio, podcasts, and short videos to increase visibility. Evaluation tools include wearable trackers, assessments, and participant incentives to monitor progress and boost retention. We've also included supplies like pedometers, print materials, and journals, plus transportation support like gas cards and ride vouchers to eliminate any access barriers. Next slide, please. We've prioritized accessibility with a large print, plain language, and translated materials. Funds for training will support staff and peer ambassadors in delivering culturally relevant messaging. A flexible funding line lets us adapt based on community feedback. And last but not least, indirect costs cover administrative needs like reporting and compliance to keep the program running smoothly. And I will pass it back over to Ken.
Very brief conclusion. The main thing we wanted to get across with this program is to increase the awareness of their susceptibility to many health issues in these communities, educate them on what they may be able to do, and empower them to be able to actually enact that change, even sustainably long after we're gone. Together, we want to make the participants stronger, which makes their families stronger, which makes their community stronger. Together, because together we're stronger, and together we are a movement for health. Thank you.
Excellent. That's nice. Okay, let's use our chat function and give them some love. Chat react function, and then you can give them some love. So I'm going to give them a tada. Fantastic, fantastic. Movement for Health, a physical activity program for African-American women 45 years and older in the United States. The location for this program will be Quitman County in Mississippi, USA. The team comprises of experts from Zimbabwe, United States, Sudan, and Nigeria. So I have a question. Actually, somebody sent this question, which I thought was interesting. The person said, I see that all of the 2 groups that have presented, people come from different parts of the world. How were you able to plan these programs when you are not in the same country? Who wants to take that? And we can also get people from MHOPE, or we can get somebody from here. It doesn't matter which group.
Maybe I can take it.
Yes, go ahead.
Yeah, I think one of the things is to develop our group working skills. So I think we also took advantage of the digital divide, where we are able now to work together remotely, plan as a team through Zoom and other platforms. Would also be able to work on other documents online, but regroup and discuss so that we are also able to maximize in terms of the availability of technology. It is also an added skill to be able to engage and collaborate with others beyond the country and the continent. So I think it was a worthwhile experience.
Anyone from Group 1, from the mHope group, who wants to talk briefly about working together for experts that are located across the world?
Yes.
Yes.
So it was really about trying to pick a time for the group meeting that's convenient for everybody. So we mostly use the time zone for US. So since that's when we normally have our weekly sessions for class, so we just used that, and then we're able to facilitate our communications. We had our meetings on Zoom. We did the normal communications on WhatsApp, and we also created a Google Docs to be uploading documents, updating, and yeah. But it was
What?
really worth it.
Thank you. One final question for Group 2. The person said, how did you come to select Quitman County in Mississippi for this program? And I've never heard about this county before. How did you come to select this county for this program?
I think I can answer that. Like I said in the presentation itself, these are some of the most underserved or the underserved, meaning not only are people around the world, as you saw, not getting enough physical activity, but physical activity is also tied to many health issues, cardiovascular issues, obesity, a lot of chronic issues. On top of that, African Americans experience much higher rates and are much more susceptible to these diseases in general, physical activity or no. On top of that, living in rural communities means less access to healthcare resources, that sort of thing. On top of that, this county is a rural county in Mississippi, which is last or nearly last in many health metrics here in the US. So, and also has the largest Black population here in the US, aside from only Washington, D.C., which is our state's capital, our nation's capital. So it's just a lot of layers that point to a huge, huge need for these potential participants for our program.
Thank you. So there's another question here from one of our guests. The budget for Group 2, that's M for Health, was significantly higher than the budget for Group 1. How feasible is raising that amount of money for the program? Group 2, that's you. How do you plan to raise the money to implement this program? $200,000.
Yes, that is a steep amount, I would say. And our population, while needy, is a little niche, a rural county in Mississippi. So I'd imagine the ability to apply to a wide range of grants would be kind of limited. However, the numbers are there, the numbers are staggering. There is a huge need. And as our society moves more towards accepting of wider cultures and wider backgrounds, you can't lie with the numbers. This whole state, Mississippi, it's majority Black. A lot of the South is majority Black. So it'd be incredibly remiss for people to continue to ignore these issues. And I think people who are providing grants or general grants for these sort of health issues, these sort of problems, understand that there is a huge need. So I would say that the general applicability for us is a little niche, like I said, but the need is there, the need is apparent, and it affects a not insignificant portion of the US, which is of itself is a highly populated country. So even in these turbulent times, the resources are out there, the people that want to help are out there, and we'll scrounge and scrape and call and bother and poke and prod and try to get the $200,000 allocated. I think
Thank
Enoch
you.
wants to
Thank you.
chime in as well.
Hold on. Let me pose the other question so you can also take those. A great program. I think someone in the team, can you address the social determinants of health and political determinants of health and how these are the drivers affecting health outcomes for those women and residents in Quitman County? Social determinants of health, political determinants of health, what are the impacts of those on the health outcomes that you have seen and that you plan to address? Group 2, Enoch, go ahead.
Okay, thank you. Just for on the previous aspect, then I'll address the political determinants of health. As we have seen in terms of our mapping of our strategic partners, apart from applying to the funders, etc., we're also going to try and cultivate local partnerships with churches, so they might also contribute in a way. So we're not only going to look at the big funders per se, but some of the local CBOs and local churches and even the private public partnerships can also come handy, or even other corporates can also chip in with some resources in terms of their corporate social responsibility. So we're going to use a multi-pronged approach to make sure that we try to harness the few resources that we can get. And I think on the political determinants of health, that's where we've also highlighted that we're going to be engaging the political leaders, the local governor for the state, and other political officials, so that we try to advocate and empower African American women to be able to lobby and request for allocation of better resources that can make the local area safe to engage in physical activity and also reduce the inequality gap. So this might need to be tackled from a political perspective.
Thank you. You have another question here. Will you conduct an outcome evaluation? If so, what are the key performance indicators you will be monitoring that will showcase long-term impact? Deidre?
Hello.
Long-term impact, yes, long-term impact. Deidre, Blaze, Kavita, will you be conducting an outcome evaluation? Yes, no? If yes, what key performance indicators will you be monitoring that will showcase the long-term impact of this program?
I'll take it.
In terms of an outcome evaluation, we're not really thought through this, since this is going to be more of a pilot. However, should there be need to do this, we'll look at various indicators like the proportion of African American women participating in our physical activity exercises. Maybe we'll look at the amount of budget allocated to address inequalities. We can also look at maybe number of partnerships that we have cultivated with the different local organizations for sustainability. So it also hinges on whether we're going to proceed and do an outcome evaluation or not. But should we proceed, then we might likely to look at those outcome indicators that are likely to show the long-term impact of the project.
Perfect. Okay. Thank you so much for all the questions. I think that is very, very exciting. We're going to move on to the next group. We still have 2 more groups, and we want to make sure we're giving everybody equal time, equal opportunity. So group number 2, M for Health. Group number 1, M Hope. And group number 3, the floor is yours.
Thank you, Dr. Romy. I will share my screen. Can everybody see my screen?
Not yet. Yes.
Okay. Yes. Thank you, Marie. Hello, good morning, and good afternoon to everybody in the program and to everybody who attended. Thank you very much. So for today, we will be presenting our proposal for our program under the name MAMA, which is short for Maternal Action for Mortality Avoidance. And it is a postpartum depression initiative in the state of Iowa in the United States. So first of all, let us introduce ourselves as the team members. My name is Doha El-Jarari, and I am the Director of Monitoring and Evaluation for the MAMA project, and I am calling today from Tetuan, Morocco.
Hi, I'm Mariangela Ndi Matos. I'm a medical doctor, PH 360 Fellow, and I'm the Director of Health and Wellbeing, and I'm joined from Birmingham, UK.
Hello, everyone. My name is Martha Kulamo. I'm the Director of Strategic Partnerships, and I'm calling in from Takoradi, Ghana.
Hello, my name is David Oseidia. I'm the Director of Programs, and I'm calling in from Virginia, USA.
Thank you. So this is a quick overview of the list of contents that we will be going over for today's presentation. We will be going over our problem statement and the data for postpartum depression in Iowa, our program goals, our objectives and methodology, the implementation plan, the staffing and personnel, the budget and financing, evaluation and monitoring, as well as dissemination and outreach towards the end. So first of all, for some quick statistics on postpartum depression in the United States and why Iowa specifically matters. In the United States, 23% of the pregnancy-related deaths or maternal deaths are attributed to a mental health crisis in the perinatal phase. And the perinatal phase refers to during pregnancy, so prenatal, as well as postpartum, so following birth for the whole first year following birth. That accounts to about 1 in 8 women across the United States who experience symptoms of postpartum depression. And across all the states in the United States, Iowa registers the highest occurrence with 1 in 7 women experiencing symptoms. This equates to about 32.3% prevalence in the United States and 29.4% prevalence across all births in Iowa. So a large chunk of it is attributed to Iowa, and it is the state that registers the highest statistics of postpartum depression and mortality from postpartum depression. Given the importance of this community, of this state, and of these statistics, our program under the name MAMA is a response to this issue. So under the name Maternal Action for Mortality Avoidance, we are a community-based program that is designed to reduce maternal mortality by specifically addressing postpartum depression and mental health crisis during this very vulnerable time in a woman's life. So we do this by targeting numerous criteria. We do this by focusing on early detection, on support, on creating an environment that is very supportive for women, on providing mental health access, on providing access to multiple services for the underserved women in Iowa, as well as on educating women in recognizing the symptoms of postpartum depression and in treating them. So for our program, some of our goals are and objectives, which will be further delved into, but the main ones are to reduce the rates of reported cases of postpartum depression in Iowa across all the communities by approximately 10% and to increase the access of mental health services by 20% in the community. And these mental health services are mainly in the form of mental health assessment for women post-birth. We also aim to increase awareness and to provide education on identifying the warning symptoms of postpartum depression. And we will do the education and awareness part of the project by hosting a minimum of 10 webinars that are led by mental health professionals, as well as by training a number of mental health practitioners to put into the community. So now for the methodology of our program, my colleague Maria will be continuing on with the presentation. Thank you.
Thank you, Doha. So the MAMA program was designed using adequate tools that helped us ground the intervention in evidence and make it measurable and scalable. So as Dora said, we identified postpartum depression as a significant driver of maternal mortality. And Iowa, 1 in 7 of new mothers experience BPD. And in USA, suicide is now recognized as one of the leading causes of death during perinatal period. So the key determinants contributing to this issue include limited access to mental health care, especially underserved communities, stigma around mental health and motherhood, and lack of peer or emotional support. These factors often lead to delayed diagnosis and treatment and can lead to serious consequences. So to respond to this challenge, our proposed activities include training over 10 peer mentors with lived experience of BPD, delivering free virtual mental health assessments and follow-ups via secure telehealth platform, and implementing community outreach initiatives to ensure inclusion and accessibility. And also we are going to ensure that we are going to be inclusive and with accessibility. So to shape the research and evaluation component of the program, we focus on a clear and practical framework. Our target group is postpartum women living in underserved counties across Iowa. The core of our intervention is the combination of structured peer mentorship and telehealth-based support. This is delivered in addition to routine care, which typically includes standard postnatal checkups, but often lacks dedicated mental health follow-up. We aim to achieve a meaningful reduction in symptoms of moderate to severe postpartum depression, and we are going to use the NDBRA postnatal depression scale as our primary tool for measurement. By grounding our program in these defined parameters, who we are supporting, how we are supporting them, and what outcomes we are looking to shift, we are going to ensure our intervention is both intentional but also measurable. This approach supports not only local impact, but also wider learning for future scale-up efforts. Next, please. Thank you. So the implementation of the MAMA program is designed to be structured, time-bound, and responsive. We divide into 3 main phases, each with clear objectives and deliverables. So in the planning phase, during the months 1 and 2, we focus on engaging key stakeholders, finalize the telehealth infrastructure, and recruiting mentors. This foundation stage includes establishing contracts and protocols to ensure that the program operates ethically and efficiently from day 1. Then we are going to move into project phase, this phase 2, between months 3 and 4. Here we will train our first cohort of peer mentors, at least 10 individuals with lived experience of PPD, and begin to enrolling up to 50 postpartum mothers across selected counties. This phase allowed us to test delivery methods and begin early data collection. Finally, the monitoring and evaluation phase spans months 5 and 6. We will collect data using the NDBRA postnatal depression scale. We are going to conduct satisfaction surveys and analyze user engagement through platform analytics. This will help us assess the effectiveness of the intervention and make real-time adjustments. This will ensure the program is both person-centered and evidence-informed, and that we are also able to learn and adapt as we go. Now I'm heading over to Martha. Thank you.
Thank you, Marie. So here we'll be talking about MAMA's theory of change, and the MAMA project will make use of the logic model. The logic model basically provides a visual map of how MAMA's inputs and activities are expected to lead to our outcomes. So with this unique model that we created for Mama, basically it shows how our support systems and services, including CHWs and workshops, will lead to our expected outcomes. So for the inputs, we are talking about funding, collaborations with clinics, the peer mentors with lived experience, like what Marie mentioned earlier, and then the telehealth platforms. And for our activities, we're going to talk about the training of the peer mentors who will be involved in the program, and also doing counseling sessions and therapy sessions on this telehealth platforms, and also community webinars talking about PPD to spread awareness and educate. Our expected outputs are 10 peer mentors, upwards of 10 peer mentors at the end of the program, 50 active participants, and 50 women enrolled in the program and continuing to use the services. Our outcomes are that by the end of the program and beyond, there'll be reduced symptoms of PPD. That is, mothers who are enrolled in the program actively participating in all the sessions will have reduced incidence of PPD or reduced symptoms of PPD. There will be increased access to mental health services, and these services will actually be put to use. That is, the mothers will actually make use of those services. And also, the overall impact is that all these efforts will lead to improved maternal well-being. So basically, the logic model shows us a structured approach. It takes us through exactly what we are going to do, how we are going to achieve them, and the outcomes expected from this project. Next slide, please. So this shows the staffing and personnel. Over here, we call it the MAMA organizational structure. This structure basically shows the flow of authority and the internal structure of the program. We'll be led by our program director who will oversee the overall project strategy. And he'll be supported by the director of health and wellness. And she will ensure that there is integration of mental health and equity principles throughout all our activities and operations. She'll be supported by consultants, clinical psychologists, and community health workers. They will provide the training sessions, they will provide counseling sessions, referrals where needed, and they'll also provide basic psychosocial support where needed. There is also the Director of Monitoring and Evaluation. She will be responsible for data tracking, impact and performance evaluations, and monitoring, and then she'll be supported by an officer. There is also the Director of Strategic Partnership, who will ensure that the relationship between NGOs and other partners, including funders, are maintained. Also, there is a Director of Outreach and Communications who will be in charge of health campaigns and other stakeholder engagements. Basically, this MAMA organizational structure ensures that qualified team members, that is, the MAMA organizational structure comprises qualified individuals who have come together as a team to work effectively to ensure that the MAMA project is culturally sensitive and is also impactful. Thank you. So with that, I'll hand over to my colleague, David.
Thank you, Martha. So let's talk about the budgets. We'll be working with a total of 157,032 cents for a 6-month pilot. We are making sure that every dollar is going toward people and services that directly impacts moms. We'll be training 10 peer mentors, that is moms who've lived through PPD, postpartum depression, and giving them stipends to fairly value their time and experience. On the service side, we've budgeted for 100 telehealth sessions, so moms can talk to professionals from home without worrying about transportation or childcare. We've also set aside funds for educational materials, outreach, and a secure telehealth platform. We've also kept a small buffer for unexpected costs, and added overhead to cover essentials like admin and tech support. The overall goal is to keep it simple, focused, and effective, and help 50 women in a meaningful way and build the foundation to do more. Next slide, please. So for the monitoring and evaluation, that is how do we know it's working? We are not just guessing. We are measuring everything we can. We are enrolling 50 moms into MAMA and comparing their outcomes to 50 others who are receiving standard care. We are using the Edinburgh Postnatal Depression Scale. That is a simple tool that asks about feelings like sadness, anxiety, or guilt. We are also tracing things like how many moms stick with the program, whether mentors stay active, and what moms tell us in follow-ups surveys. We'll also be looking at emergency visits to mental health as a long-term safety check. So the bottom line is that we want to know if MAMA is making moms feel better and if it's worth scaling up in a real world that is a cost-effective way. Next slide, please. When it comes to this dissemination and outreach, we know that even the best program doesn't help if no one knows about it. So that's why we are going where moms already are. That is Instagram, Facebook, TikTok, and also creating relatable, stigma-free messages. We are just using real stories, not just statistics, and working with community influencers to spread the word. We've got a project website with info and resources. Also, we have posters and leaflets for clinics, libraries, and churches. And we will be reaching out to healthcare workers and public officials to make sure they know MAMA exists and that it works. The overall goal is to make it easier for a mom to say, I'm struggling and I know where to get help. Next slide, please. Next slide.
I changed the slide. Can you not see it? Wait, give me a minute.
Okay, yeah, I see it. So we'd also be using influencers, healthcare providers, community and faith-based of organizations and public health officials, and email briefings. Next slide, please. So in conclusion, I would say at its core, MAMA is about saving lives by showing up for moms when they need it the most. 1 in 7 mothers in Iowa experience postpartum depression, but most never get the support they need. So what MAMA does is that we are offering a simple but powerful model that includes peer mentorship, virtual therapy, and education, all wrapped in community support. We are starting small with 50 moms, but what we could learn could change how we could support maternal mental health across the state and beyond. So this isn't just about numbers. It's about moms like the ones we all know, our sisters, our cousins, our friends, who would need somebody to listen to and a safe place to heal. In conclusion, I'll say MAMA is proof that when we meet moms where they are, we don't just reduce depression, we restore confidence, health, and hope. Thank you.
Excellent. The MAMA group, that's really cool. Maternal action for mortality avoidance. Really, really creative. And hey, kudos for excellent time management. I didn't have to struggle to chase you around for the time. So kudos on that. So I have a couple questions here that have come in. I think you answered one of it. So this is one. It says, how do you plan to engage? Oh, no, it said, do you have plan to engage men in this project? If so, how can men be engaged in this project?
So I can answer that. So we are going to have resource. So our webinars and our outreach contacts is create awareness. So it's not only for the mothers. So the peer mentoring and the mental health support is going to be more direct to the mothers, but also we are going to engage with the communities and including the family, the partners and whatever is the family structure, but in the people that is going to give support to this mother. So we are going to intend to create the resources so they can understand and then have a conversation about, but also even if you don't have a specific member of your family, but you're aware of the project, and if you know someone at your work or you're in a neighborhood, you can direct this person to our project.
Very good. By the way, this team comprises of experts from Morocco, from UK, United Kingdom, from Ghana, and as well as from the United States. So this is my question. I saw that you had an opportunity to request $200,000, but you requested only $157,000. How does that make sense for you?
Like I earlier stated in the beginning, we wanted to make sure that every dollar was going towards the program. And so when we did our budget, there was no need to go above, even though we had a $200,000 benchmark, but we wanted to make sure that the program was intended for the recipients, that is the moms. So that is why we stuck to that.
That's very good. That's really very good. Another question here I have, it says, the location of the program, Iowa as a state is too large. Are you planning to base this somewhere in Iowa since this is a pilot?
I can go ahead and answer that. So for our program, we do realize that Iowa is quite a large undertaking. It is because through our research, we did not find enough data concerning a specific county that registers like the highest numbers. It was just regarding the state. So we thought that for our pilot, we can just try a general county in the state. And if we see really good results, we can implement the same program or similar programs and increase the range and target as many counties as possible to solve the issue in the state as a whole.
Excellent. So the statistics here is very grim. 1 in 7 women in Iowa experience postpartum depression. Group 3, thank you so much for doing an excellent job. We are looking forward to seeing what Mama and how Mama is going to transform lives for mothers and for families. Thank you. So please use your react button and show the Mama group some love. Perfect. So we are now going, you save the best for the last. So we are going to get to hear the last group. This group is exciting. I got a preview of what is going to happen, but we're going to see how this program is going to happen today. So group number 4, the digital floor is yours.
Hello everyone. So our group representing the Brothers for Better Hearts project. So my name is Precious Osawe. I'm a public health PH 360 fellow, and I'm the program director for this group. And I'll hand over to other members of the group to talk about themselves.
Precious, where are you calling from?
Oh, I'm calling from London, United Kingdom.
Thank you. The next person should join.
Hello, everyone. My name is Renique Vissi. I am the Director of Monitoring and Evaluation for this program. I am calling from Georgia, United States.
Hi everyone, I'm Jemima Victoria Manfo. I'm a PH 360 fellow. I'm the Director of Health Education, and I'm calling from Accra, Ghana.
Hello, my name is Riten Excess. I am the Director of Marketing and Communication for Borders for Better Hearts Project, and I am joining from Florida, United States.
Hey everyone, how are you doing today? My name is Ryan Benson. I'm a PH 360 fellow as well. I'm serving as the Director of Financial Management for Brothers with Better Hearts, and I'm joining you all from Portland, Oregon.
Good afternoon. My name is Sierra Martin. I'm a PH 360 fellow. I am the Director of Partnerships, and I am joining from Atlanta, Georgia, United States.
Okay, so in this presentation, we'll be talking about our problem statement. We'll talk about our goals, our objectives, our methodology, the theory of change, the outcome, the timeline, our partnership, our evaluation plan, our staffing plan, our budget, and we give a conclusion. So I'll hand over to Ryan to take us in the next section.
Thank you, Precious. Thank you all again for joining us and sitting through all these presentations. So for decades, coronary heart disease has remained one of the world's leading killers, taking over 9 million lives annually from our global community. Here in America, despite the billions invested and phenomenal medical research that's conducted here every year, the devastating grip of coronary heart disease really has a hold on our population. And unfortunately, the losses and pain are not distributed evenly. In Florida, coronary heart disease is the leading killer, responsible for 1 in every 5 deaths statewide. And if that wasn't bad enough, Black men over 40, specifically in Miami-Dade County, that's in Southern Florida, for those not familiar, are absolutely being devastated by coronary heart disease. To put it in perspective, coronary heart disease has a mortality rate of 79 per 100,000 people unadjusted. Whereas if you look at coronary heart disease for Black men over 40, it's nearly double that at 135 per 100,000 people. This is just not acceptable from our perspective. So we're looking to address that, and tackle some of these root causes. Move to the next slide, please. So the statistics aren't just, shocking. They're signs of deeper inequalities. For decades, there have been barriers built intentionally or unintentionally that have concocted sort of a perfect storm for coronary heart disease to manifest as a problem in the Black male community, specifically in areas like Liberty City, Overtown, and Brownsville. This means that there's limited access to preventative care. Food insecurity means that people aren't able to get the nutrition that they need as recommended by the FDA and general best health practices. This insecurity and mistrust of the healthcare system, has led to just a staggering economic toll. Loss of productivity due to these health problems has totaled 86 million. And then there's the 94 million on top of that in direct medical costs, as may not be clear to those of us joining around the world. The United States does not have a single payer health system, so healthcare is not guaranteed. If you can't work, you're not covered. As you can see, this would compound the issue. So next slide, please. So we're looking to form a group, Brothers for Better Hearts, that will address these gaps. This campaign isn't just about, reaching out to Black men. This is about the whole community. Black men are the tip of the spear in this problem. And by embedding ourselves in the community with evidence-based education, high blood pressure screenings, health coaching, right in the places where Black men are, instead of making them come to us, we're going to come to them, their churches and barbershops and community centers, which will hopefully really turn the tide. And I'm going to turn it over, excuse me, to my colleague.
Okay, so I'll be taking us through the goals and then also the objectives for the project, Brothers for Better Health. So our main goal was to reduce the risk and then also the burden of coronary heart disease among non-Hispanic Black men aged 40 and above in Miami-Dade, Florida state, through targeted education, early screening, and then also community engagement. To achieve our goal, we decided to focus on 4 main objectives. So the first one is to improve cardiovascular health literacy. This is to for us to increase people's understanding of heart health, the risk factors of heart disease, and then also the preventive strategies. Because we believe that when our brothers are well informed, then they'll be empowered to make better health decisions. The second objective was to promote healthy lifestyle changes. We are looking to encourage our brothers to adopt healthy lifestyles such as regular exercise, intake of balanced diet, reducing alcohol consumption, all in the efforts to reduce the risk of heart disease. The third objective was to encourage early detection and also screening so as to reduce the risk of heart disease. And that is going to be done by highlighting the importance of routine checks. That's the blood pressure checks, cholesterol checks, blood sugar checks. This way, once the problems are detected early, we're able to prevent serious complications. And then finally, to strengthen care referral pathways to healthcare services. Doing this by focusing on improving how patients are directed to the right healthcare providers quickly so that there will be a timely treatment and then also follow-up care when needed. I would hand over to my colleague, Retain.
Okay, I will be presenting methodology framework. Black men over age of 40 residing in Miami-Dade County, Florida, educating our targeted population risk factors associated with coronary heart disease, no intervention or compared other countries in Florida, increase CHD awareness among the target population in 12 months. Next slide, please. Okay, recruitment strategy. Community outreach via churches, barbershop, health fairs, and digital out. Targeted enrollment 2,000 participants over 12 months. Inclusion criteria: non-Hispanic Black men 40 plus residing in Florida, Miami-Dade, Florida. Intervention activities: monthly health education workshop, hybrid format, free biometric screening, blood pressure, cholesterol, glucose, nutrition and fitness associated, led by Black health professionals, CHD awareness challenges and intervention, health journals, groceries card. Next slide, please. Evidence-based foundation, adapt from community guides, recommendation in cardiovascular disease prevention and community health outreach strategies, tools and platform, mobile friendly outreach like text alerts, WhatsApp group, digital signups, printed educational material and development using CDC and content data collected via REDCap or secure database Excel. So time highlighted. First and second month planning, staff out onboarding and promotional campaign. Third, it's a 10 months program implementation, monthly workshop, continuous data collection, month 11 to 12 evaluating, reporting, and final dissemination activities. I will hand over to Precious to present the outcome and theory of change.
Thank you so much. So I'll be leading the last slide on the theory of change. So the program is guided by the logic model framework, which is to show that our inputs, our activities, and our outputs will lead to a desired outcome. So for our inputs, that's our funding, and we are going to use about the $200,000. Then our staffing, those are the people that are going to help us to implement this program. The screening equipment, because screening is one of our major objectives for this program. Then our partners, which will include the community partners, and we'll come to that in the other slides. Then the materials that we're going to use for this program. So what is our activities? Our activities are community outreach, the recruitment of the individuals, the education sessions, the health screenings that we're going to do, the PA education trainings that we're going to carry out. So our expected output. So we want to have reached about 2,000 participants. We want to have shared 1,500 educational materials. So we hope that we'll get about 500 individuals screened. So we hope to also have like 40 outreach events. We want to train 20 community health educators. So what is our outcome? Our outcome is that at the end of this, we'll have an increased CHG knowledge of our participants. The participants have improved health behaviors, and then we're able to detect those that have risk of coronary heart disease. And generally, we hope that this target population are able to experience an improvement in their quality of life. So we're going to reflect it out to our short-term outcomes, our medium-term outcomes, and the long-term outcomes. So for the short term, the timeline is about from the 1st to the 3rd month. We hope that our participants will have like a 70% increase in participants' knowledge on the risk factors of CHD. We hope to have an increased screening uptake. We hope to have about 30% increase referrals of those individuals are at risk of CHD to the healthcare services. So from about 3 months to maybe 6 months until the end, we hope that the participants have an increased physical activities, their BMI is reduced, we have achieved low smoking rates. We hope that we have participants that have low blood pressure and lowered cholesterol. So we hope that the peer educators are properly equipped and have the capacity to address these cardiovascular health issues. They can address it, they can educate the community that we're trying to target. And we hope that generally our target population have improved heart health literacy. So in the long term, that is from 12 months and afterwards, we hope that the community have a decreased level of coronary heart disease mortality rates. And also we hope that the incidence of coronary heart disease is reduced and the burden on the healthcare services is also reduced as well. And generally, we hope that we will see an improved quality of life in our target population. So I'll hand over to Ciara to continue the next slide.
Thank you, Precious. So the Brothers for Better Hearts program has a 12-month implementation program. So month 1, we'll start by finalizing the name, acronym, and the look of the program. We'll create flyers, videos, and social media content that speak directly to the Black men in the community. We'll launch our social media campaign to raise awareness and start conversations. And we'll distribute materials to trusted community sites like churches, barbershops, and rec centers. Month 2, we'll secure partnerships with trusted organizations like churches, local nonprofits, and health centers. We'll create a full calendar of the outreach activities. We'll begin collecting pre-surveys from participants. We'll finalize our logic model and the theory of change. Month 3 is when the outreach begins. We'll host a kickoff community health fair. During this health fair, we'll distribute more educational materials and also have educational sessions led by Black health professionals and free heart health screenings. We'll also collect attendance data to track who we're reaching and how many people are engaging. Next. In month 4, we'll begin weekly pop-up events in places men regularly go, like parks, churches, barbershops. Partnerships with local radio stations and community leaders will help promote these events to make sure we reach as many men as possible. We'll also listen to the community by collecting midpoint feedback on what's working and what needs adjusting. Month 5, we'll implement workshops on high-risk behaviors where community members can learn about poor diet, reducing stress, smoking, and managing blood pressure and other behaviors that increase their risk of coronary heart disease. We'll introduce mobile health screenings so people who do not have access to a primary care physician can get checked where they are. And lastly, for month 5, we will begin a peer education program where members can hear testimonies and be educated by other community members in a way that feels real and relatable. Month 6 is the mid-year review. We'll analyze participation data where we check how many people are joining and continue to stay involved. We will conduct focus groups to determine what is working and what needs to be changed. And we will adjust our program approach based on what the community is telling us. Next. Month 7 is reinforcement. We'll update and reshare educational materials to keep the messages relevant. We'll host a coronary heart disease awareness week with events, talks, and screenings that focus on heart health. We will bring in local influencers and clergy to help spread the word and encourage participation. In month 8, we'll train volunteers and community champions so they can lead conversations and help others stay on track. We'll increase media exposure to raise awareness even more. We will continue offering workshops and health screenings in places where people feel comfortable, like churches and barbershops. Month 9 focuses on sustained engagement. We will encourage men to follow up with healthcare providers after their screenings. We'll launch support groups where men can share experiences, ask questions, and get referrals to services like nutrition, counseling, or mental health support. We will begin post surveys to see what's changed since the beginning of the program, such as healthier habits or increased awareness. Next slide, please. Month 10, we will compare pre and post survey data to see how much knowledge, behavior, or health status has improved. We will run another set of focus groups and interviews to hear directly from participants. We assess how much change has happened in terms of heart health understanding and lifestyle choices to get a clear picture of what the program has accomplished. Month 11, we'll start organizing all the findings so we can share them with the right people, write an evaluation report that summarizes the outcomes. We prepare a policy brief for policymakers and community leaders to advocate for more funding or support. We will also schedule meetings with stakeholders like hospitals, nonprofits, and local government who can help expand or sustain the program. And lastly, in month 12, we'll close the year by sharing results and celebrating our success. We'll send out a newsletter, hold community forums, and share the results through social media and public events. We'll present the program at local and national conferences, and we will submit final data and reports and work on publishing the results for the public and other professionals. And finally, we'll host a celebration event to thank the community, volunteers, and recognize the lives that we have touched. Next, please. Next, I'm going to talk about the partnerships. So the government and public agency partners, such as the Health Resources and Services Administration, plays a key role in addressing healthcare access issues among underserved populations, including Black men. At the state level, the Florida Department of Health can provide valuable county-level health data and potential state grant opportunities. And additionally, the National Heart, Lung, and Blood Institute offers research funding and resources that align directly with our health program. Next. Our health-focused foundations are another vital source of support. The American Heart Association provides grants, health equity partnerships, and educational materials to boost local impact. The Robert Wood Johnson Foundation is known for funding innovative efforts to address health disparities and social determinants of health, making it a strong match for this program. Similarly, the Aetna Foundation supports community wellness initiatives in underserved communities, and the Kaiser Family Foundation can offer valuable data and policy insights to strengthen the program's educational components. Next slide. Partnerships with faith-based and community-based organizations are essential to enhance trust in the community. Local churches, including AME, Baptists, and megachurches, provide trusted venues for these outreach events and screenings. Organizations like the Urban Health League of Greater Miami, 100 Black Men, and NAACP Miami-Dade branch bring deep-rooted community ties that have the ability to mobilize the community and provide expertise in health initiatives. Next slide. And lastly, corporate and media partners can help amplify the program's reach and provide logistical support. Local hospitals and health systems like Jackson Health and Baptist Health South Florida may contribute staff and screening tools or help sponsor events. Health insurance companies like Humana and United Healthcare could support the program through community investment funding. Local radio stations and urban media outlets such as Hot 105 are ideal for sharing public service announcements and promoting events. Retail foundations such as Publix and the Walmart Foundation are known for supporting community wellness efforts and could provide additional funding or in-kind support. And now I'm going to send it over to my colleague.
Thank you, Sierra. That was wonderful. As you can see, all of our presenters are bringing something different, and that's important when you're building a community. Oh, I'm sorry.
Okay, I will be discussing our evaluation plan. For Brothers for Better Hearts, we aim to conduct assessments throughout the duration of this program, meaning that we will be observing and tracking participant health outcomes. Furthermore, managing our program's integrity, reliability, and engagement, as well as ensuring that our intervention methods are delivered as intended. For research and data collection, we will utilize various measurements, those relating to health like blood pressure, cholesterol, body mass index, and we will also conduct surveys like KAB, knowledge, attitude, behavior, which supports our overall goal of health education, and it suggests that lifestyle behavioral changes are affected by one's knowledge and attitude. Additionally, we will be tracking appointments, screenings, and participant logs or journals, and our evaluation dimensions include productivity and reach, and enrollment, attendance, and program delivery effectiveness. Our impact includes risk reduction, quality of life, behavior change, and capacity building in staff training partnerships and sustainability plans. I will now be handing it over to Ryan. Thank you.
Thank you, Renique. Apologies for the earlier interruption. But as I was saying, we've assembled an incredible team. As you've seen, all the presenters are both dynamic and highly competent. Our leader, Precious, has a master's in public health, and she's been an incredible leader and will carry this organization forward. Dr. Jemima Manful is going to be leading up our community engagement. Recently minted public health master is Sierra Martin, leading our partnerships. Myself, Ryan Benson, will be responsible for all financials, and as you just heard from Renique, she has a handle on all of our monitoring and evaluation. And Ratan, also a Master of Public Health, will be handling all of our marketing and communications. Next slide. This dynamic team focused on basically delivering impact. We tried to put the needs of the program first, and you can see that represented in the budget. We're spending almost a third of the money we hope to raise on screening supplies and materials. This is going to maximize impact, and we're looking to deliver things efficiently and at as low as cost as possible. The rest of the money, we're trying to get into community hands through projects, media. This is going to not only boost awareness and engagement, but also, we're hoping to put some money into the community as well, to mitigate some of that impact we talked about earlier. This budget is skinny by design, partnering with, as we said, churches through co-location, looking to minimize overhead costs and administrative costs. And with all that said, I'm going to turn it over to Precious.
Thank you. So in conclusion, the BBH project, it offers a community-driven initiative. And with this project, we aim to decrease the prevalence of coronary heart disease by focusing on education, by focusing on screening and behavior changes for the individuals we're going to work with. So with these evidence-based strategies, looking at our strong partnerships and a focus on capacity building, we aim that with this initiative that will bridge the gap in inequalities and lay a long-lasting foundation for health improvements. Thank you very much.
Fantastic. BBH, Brothers for Better Heart. Please use the react button. Let's give them some love. This is really, really good. Well done. Well done. I'm going to give you a heart. Fantastic. This is great. This is really great. So let's go to it. I have questions immediately. So the first question again is, what role do you see for Black women in this project? Who wants to take that? Come on.
Happy to take that. Black women are obviously the other half of the Black community, as we're focusing on Black men. They are going to be hopefully engaged in all of the volunteer efforts through the churches, through the health screenings. I mean, as you can see, our team is composed largely of Black women. These are people that bring incredible expertise to this problem. And so that's how we're hoping to engage Black women.
All right. My next question here is, how portable is BBH?
Yeah, I'll answer that, Dr. Rami. We can say BBH is very portable because we are going to focus on the three major areas. So we're going to ensure that we're empowering people to take charge of their health. We're going to ensure that people are, they have good literacy of their health. They can assess when they are at risk. They can read their BMI. They can help themselves. They can be physically active. So I believe BBH is very portable.
I have another question for you. What is driving the high rate of heart disease among Black men in Miami-Dade? What did you find from your research?
From our research, we found the highest drivers were food insecurity, the lack of physical activity, and awareness. So folks aren't aware that the diet and habits every day are contributing to these problems. This is a slow burning problem. So when you're young and you can eat whatever you want, those habits become ingrained, and we need to break that cycle through education, awareness, and empowerment. And that's what Brothers for Better Hearts is hoping to do.
Very good. Thank you. Let's see. Is there another question here? Yeah, so a comment. Yeah, somebody said a good idea to incorporate the Heart FM 105.5. That's a good way for reaching Black men. Okay, another question. What are the top 3 barriers that you see in implementing this program? And how will you address those 3 barriers?
I can give you one. I think one barrier would be getting people to join. I know in my personal experience, Black men in particular are very, I don't want to say scared of the doctor, but they don't like to go to the doctor. They're scared that they're going to tell them that something that they don't want to know. So they just rather not go. So I think that that's one big barrier, but I think that we can help improve that by bringing in other Black men from the community, well-respected Black men, to encourage them to go get some help. But I think that's one barrier.
All right. Thank you so much. So we have, today was actually a festival of knowledge. I have learned a lot myself. Group 1 with team members from China, US, Nigeria, and India. MHOPE, Mental Health Outreach Program for Youths. The program proposes to address mental health for young people at Babcock University High School in Ogun State, Southwest Nigeria. Then we went on to group number 2, M for H, Mental Health for Movement for Health, a program to address physical inactivity among African American women 45 years and older in Quitman County in Mississippi in the USA. The team comprised of experts from Zimbabwe, the United States, Sudan, and Nigeria. And then we had the 3rd group, the MAMA group, Maternal Action for Mortality Avoidance, with team members from the UK, from Morocco, from Ghana, as well as from the US, addressing proposing a program that will address a community, a state where 1 in 7 women experienced postpartum depression. The last but no way the least is Brothers for Better Hearts, the BBH project, which is comprised of a team from the US, from UK, from Ghana, trying to propose a program to address heart disease among African-American women, African-American men in Miami-Dade, Florida, in the United States. So thank you so much. For all of you, this is truly a manifestation of the training, of the development that took place in the last 3 months. I hope you will continue as experts in program design, as experts in designing interventions. Remember, whatever name they'll be called. They could be called projects, they could be called campaigns, they could be called initiatives, they could be called advocacy. Remember, do not be tricked by the name. You have the expertise to address programs, to address issues, public health issues using programs. You all did it. And I want to congratulate all of you for immense job. It's been a pleasure having you all in the last 3 months. And I hope as you join our global community of Peer 360 fellows that you will continue to remain engaged. Tell us, give us the good news. And remember, you continue to have the opportunity for your one-on-one so that we can get a look at what your career plans are. On behalf of the team, I would like to wish you wonderful careers. And we're going to pause the recording and then have some some few comments. Brown, can you pause the recording? Thank you. Okay, so this is a good time.